Alright, this is a particularly super high yield subject. I need you guys to zone in here, pay attention with everything you have because the board examiners will make it rain on you with questions about vasculopathic changes. The first thing we need to do is analyze the name. Arterio indicates we're talking about arteries, and sclerosis means hardening. Essentially, we're going to talk about hardening of the arteries. The first one that we need to discuss is Monckeberg, which is also called medial calcific sclerosis. So, the medium area, or the media, is calcified and sclerotic. So, the first one up for discussion is Monckeberg's arteriosclerosis, aka medial calcific sclerosis. I personally like the name medial calcific sclerosis, not because I don't want to give our old friend Monckeberg credit, but rather because the name tells us what exactly is going on in this disease. Media, so obviously the media of the artery. So there's some problem with the tunica media. And the calcific sclerosis indicates that there's hardening of the media due to calcium deposition. So why did I just throw this image up on the screen for us? Well, the patient came in because he fell and hurt his leg. He had no complaints besides the fall. Wait a second, is that crazy? No. Look at this diagram. Do you see the pipe stem looking arteries? These are classically referred to as pipe stem arteries because they look like the tube-shaped pipe handle on smoking pipes. Yeah, I've never seen one, but that's what I looked it up and that's what they said. More importantly, just remember the radiographic image and then remember that buzzword pipe stem arteries. Usually there's significant calcification of the femoral arteries, which is why we can see them on x-ray here. The femoral artery, right here, and also here. The reason why this disease occurs is not yet clear, but I like to think about it and I present it in a way that makes sense. So it's vascular smooth muscle cells within the media start to express factors that only cells involved in the regulation of bone are able to express. So normally, they don't have this, but something went wrong, and now vascular smooth muscle cells in the media start expressing growth factors related to bone. So basically, it's vascular smooth muscle cells gone bad in the media. They start acting like osteoblasts. And when you have osteoblasts in your media, that's not good, particularly in places like the radial and ulnar arteries and femoral arteries. They start depositing bone into the media, and there's calcification that goes on. This does not cause any damage, nor does it cause any clotting because the intima is just fine. The only thing that's wrong is that there's hardening of the media because it is decided to be bone. So let's talk about other more common, more relevant types of arteriosclerosis. Arteriolosclerosis, note that we have added an L and O here because we are talking about vessels smaller than arteries. There are two types of arteriolosclerosis that we will focus on here. Notice that because arteriolo is in the name, we are talking about the hardening of smaller arteries and arterioles. So let's start with hyaline. Do you see this homogeneous pink material that is thickening the vessel and narrowing the lumen? Obviously the lumen is narrow, the two blue arrows are pointing to it. In hypertension or diabetes, you can see this. So in the situation of hypertension, there is such high pressure that plasma proteins will literally be smashed and pounded on the endothelial cells until eventually the integrity of the junctions between the endothelial cells is lost. And we can actually push and drive some plasma proteins into the basement membrane that the endothelial cells sit on. This causes inflammation, and you can guarantee that this vessel will respond with a nice cytokine cocktail that will activate our vascular smooth muscle cells and fibroblasts. And this will lead to the deposition of collagen. And when you stain with this hematoxylin eosin stain, you get this nice pink amorphous looking material within the vessel wall that we like to call hyaline. So just think about it. This vessel is getting pounded with high pressure. The body's like, hey, maybe I should reinforce this area with some collagen and muscle to ensure that we can keep up with this high pressure. The term hyaline kind of got stuck with this because it is glassy and pink after you stain with the hematoxylin eosin. So what do we know about hyaline arteriolosclerosis that you see in diabetes? It's different from hypertension. Same concept, except that instead of damaging our endothelial cells with super high shear stress like in hypertension, in diabetes, uncontrolled levels of high glucose lead to non-enzymatic glycosylation of endothelial cells. This leads to oxidative damage or stress, and eventually endothelial cell dysfunction. There's an inflammatory response just like the one in hypertension because there's damage going on. The end result is that the activation of vascular smooth muscle cells and fibroblasts leads to deposition of collagen. Again, we get hyaline deposited in the vessel wall. Now the last one we need to discuss is hyperplastic arteriosclerosis. Now why does this happen? Remember that in malignant hypertension, the pressures are crazy. 180 over 120. It's not like the slightly elevated pressures you see in chronic hypertension that leads to the hyaline-like changes that we saw. This vessel just gets absolutely destroyed. The endothelial cells and the basal membrane just cannot hang with these pressures. The damage leads to a compensatory-like process in which you start creating multiple layers of basal membrane concentrically towards the center of the lumen. Therefore, you gradually obliterate your vessel lumen. This is called fibrinoid necrosis because it refers to the fact that the damage to the vessel wall allows fibrin to leak into the vessel wall and deposit around these new basal membrane layers that we are stacking on top of each other. So that is why it looks like an onion, because we're stacking new layers of basal membrane, trying to keep up with those high pressures, and then fibrin leaks in as well. And it gives you this nice presentation that literally looks like a blooming onion from Outback Steakhouse. Now, whenever you stain with hematoxylin and eosin, it binds to things like collagen and fibrin with a nice pink glassy appearance. So what is the difference between arteriosclerosis and atherosclerosis? Well, the next slide will tell us this. First, let's look at the name. Athero means gruel in Greek, and sclerosis again means hardening. Hasn't changed. Gruel has some weird yellow appearance. It looks like potato meal. This is actually like mashed yellow potatoes. This is what the Greeks used to eat. It's actually a type of food. So when the ancient Greek physicians looked at some of the arteries of people, they noticed yellow deposits in very stiff arteries. It looked like the gruel that they ate, but little did they know that they were actually looking at atheromatous plaques in the vessel lumen wall. They were pretty smart because they named these plaques after some of the food they ate, but not as smart as you are. You know that these plaques are cores of cholesterol and cholesterol esters covered with a fibrotic cap. So here's our cap, and cholesterol is inside. It looks yellow. So before we think about the pathophysiology of this disease, you need to be aware of who is at risk. This is important for screening purposes in your patients. Obvious factors are ones that cause direct endothelial cell damage, such as smoking, hypertension, and diabetes mellitus. Now, hyperlipidemia is obviously a risk factor because high levels of lipids can enter the vessel wall. Any type of lipid, not just cholesterol, can accumulate within the vessel wall. Now, increase in age. Older people have an increased risk for atherosclerosis due to the accumulation of these deposits over life. Postmenopausal females are particularly increased risk because estrogen is a potent stimulator of HDL, so these females have lower levels of HDL. And with lower levels of HDL, they are lacking the appropriate level of reverse cholesterol transport provided by HDL. Remember, there's less extraction of cholesterol from the vessel. HDL takes cholesterol out of the vasculature and returns it to the liver. The last is a rather obvious one. If someone in your family, so genes, had it, then you're automatically at risk because you guys share that stuff called DNA. Now, before I start, please allow me to emphasize the important things to really quickly revisit and highlight some of the things that we will see when we go through the pathogenesis. The plaques that we have, remember the fibrotic cap with cholesterol core, they can do a couple of things. They can occlude the lumen, which leads to a decrease in flow. They can also rupture and cause complete blockage or acute narrowing, which also causes a decrease in flow. They can block diffusion of blood to the endothelial and internal elastic lamina layers, which causes necrosis of these cells and sets you up for weakening and risk of aneurysms. Great. Let's use this awesome image on the next slide to understand the pathophysiology behind the development of this disease. So the atherogenic process is one of the complex and therefore highest yield sections in the first aid cardiac pathology section. First, we have to start with some of the endothelial cell damage. So here are endothelial cells. This is under the endothelial cells. And this is our media. Now, endothelial cell damage can occur by any type of injury, including mechanical shear stress, chemicals, immune complex deposition, but we are going to start with how excess LDL, and again, LDL is composed of cholesterol, and then these little yellow dots represent the lipid component. So our patient has hypercholesterolemia. As you can see, there's high levels of lipid floating around their blood, or cholesterol. These yellow dots are LDL, or whatever lipid you want to talk about. Over time, there will be an accumulation of LDL in the intima. This is our intimal layer here. Is this bad? Yes, because it will be oxidized. Oxidation is bad because it creates dangerous byproducts like reactive oxygen species. Reactive oxygen species cause direct damage to endothelial cells. What happens when you damage endothelial cells? Well, they release chemoattractant substances such as monocyte chemotactic protein 1. The name tells you a lot. Monocyte probably attracts monocytes, right? Chemotactus probably attracts monocytes with some sort of chemical signaling mechanism and it's a protein. So, chemotactic protein, monocyte, makes a lot of sense, right? Monocytes get this invitation to party and then they come back and perpetuate this process. There's also new markers on endothelial cells called vascular cell adhesion molecule 1, VCAM1. We've seen that before. So now monocytes are invited to the party. As you can see here, there is a signal for chemotaxis by MCP1, which is monocyte chemotactic protein 1, and then there's ability for these cells to now cross this barrier by the expression of VCAM1. When monocytes are exposed to the extracellular matrix here, it causes them to be converted from monocytes into macrophages. So, our endothelial cell damage has triggered this process, and now we're at the point in which we are allowing transmigration of monocytes, here, across the endothelial cell barrier. This is a protective mechanism, because those endothelial cells are calling for help from the macrophages to get in there and phagocytose the oxidized LDL. The oxidized LDL is causing problems. It's creating reactive oxygen species and causing endothelial cell damage. So here come our monocytes say, hey, I'm going to come in here and I'm going to phagocytose our LDL. Well, the process of oxidizing LDL is bad, but so is the process of phagocytosing it, even though it is a protective mechanism. Now that the macrophages finally have joined this throwdown party, how does the oxidized LDL interact with the macrophages? Well, the process of oxidizing LDL made a bunch of dangerous molecules, such as hydroperoxide and reactive aldehydes. So, we made hydroperoxide. These bad boys actually modify lysine residues directly on the LDL ApoB protein receptor. This makes the LDL ApoB protein on LDL super high affinity for the macrophage scavenger receptor and toll-like receptor 4. These are present on macrophages. So again, these molecules made the LDL ApoB protein receptor very high affinity for these macrophage receptors. Binding the scavenger receptor tells the macrophage to phagocytose the LDL. So eat it up. This is how you get the classic foam cell appearance, which is this bad boy right here. Foam cells are just macrophages that have eaten a sundae buffet of oxidized lipids, particularly LDL. Now what happens when you activate TLR4 or toll-like receptor 4? It activates the macrophage to start producing nuclear factor kappa beta. This is really bad. We know that nuclear factor kappa beta is the mother of all inflammatory transcription factors. Activated macrophages are a jack of all trades. They literally can do anything, including release of platelet-derived growth factor, fibroblast growth factor. Now what do these do? Well, these are chemotactic and stimulatory for fibroblasts, right? They say, hey, fibroblasts, come in here and start depositing collagen. And for vascular smooth muscle cell migration towards the center of the intima where the macrophages are sending out these signals. Unfortunately, for this vessel, when things occur in the intima, it narrows the lumen, and it increases the risk for rupture and exposure of subendothelial collagen, causing a potential clot or thrombus. Now, again, where are the macrophages? They are in the intima, trying to clean house, get rid of the oxidized LDL. So now we have macrophages, smooth muscle cells, and fibroblasts in this intimate party in the intima. Yeah, sorry, bad attempt at a joke, but let's keep rolling. These newly recruited fibroblasts start depositing proteoglycans and collagen everywhere at the same time that our vascular smooth muscle cells are growing and duplicating. So again, as you can see here, these deposition of collagen fibrils and then smooth muscle cells start moving into the intima from the media. This leads to pathologic proliferation and deposition of extracellular matrix within the intima. What makes it even worse is that the oxidized LDL that the macrophages consume cannot be broken down, and those poor macrophages can literally explode, releasing all of their contents and inflammatory signaling molecules. So what happens when you explode a macrophage that is full of LDL cholesterol oxidized crystals? Those crystals will go directly into the intima. So all that work those macrophages did to clear out the oxidized LDL is now worthless. We're actually in a worse position now because we've released crystals into the intima of the vessel, and all of the cytokines within the macrophage are now floating around freely in the intima. You can bet your step 1 registration code that these cytokines will continue to stimulate this process. So now, we have dead macrophages spilling out oxidized lipids and cholesterol continuing to accumulate in our intima. Here are these yellow blobs of lipid that we do not want in our intima at all. Again, we have fibroblasts depositing extracellular matrix type of tissue components, and vascular smooth muscle cells won't stop growing and transporting into the intima. This is the point at which we have our fibrous cap. If you want to get specific, there's usually a fibrous cap of smooth muscle, so vascular smooth muscle plus collagen, and this really thick collagen is overlaying the macrophages, T cells, and even more vascular smooth muscle cells. Last but not least, because it is the deadliest part, is that there's just a necrotic core with cholesterol, esters, and crystals all inside of it. So necrosis is from the macrophages that continue to accumulate and die because they cannot break down those cholesterol esters. This obviously is just an environment of endothelial cell damage, so there could be leakage of plasma proteins into this vessel wall, which further exacerbates the damage. Now, what kind of image are they going to show you? They love showing this image because they can ask you about any part of the pathogenesis of atherosclerosis. What are we even looking at? Well, let's start. This is the lumen. It is incredibly small compared to normal because of all the collagen deposition and vascular smooth muscle migration and proliferation. So what about this section here? Well, as you can see here, there's some sort of crystal-like gaps where the cholesterol crystals were washed out during the fixation process. You can see the spaces that the crystals previously occupied. Okay, so when we get to the plaque with the fibrotic cap, are we done? No. Everything in the body is a dynamic process. This plaque will continue to progress because the cells within it die, release growth factors, and it's a continuous process. This leads to continued recruitment and proliferation of fibroblasts, vascular smooth muscle cells, and angiogenesis. Wait, angiogenesis? Why would that make any sense? Well, it's not intentional. Remember, the macrophages die. They leak all their contents, including vascular endothelial growth factor, and this causes the growth of very weak vessels. They're very fragile, and they grow into the sides of the atheroma, like so. These really weak vessels on the sides of the atheroma can rupture and bleed into the atheromatous plaque. If you bleed into a plaque, then you distend the plaque. That makes that weak fibrous cap really susceptible for rupture. Now, what is inside of the plaque? It is full of necrotic cells, collagen, fibronectin, and fibrin. All the good stuff that you need to immediately trigger a cascade of platelet plug formation and clotting. And this is exactly how acute thrombotic events occur. You bet, exactly how it happens. You'll have the formation of an acute thrombus that could potentially finish occluding the lumen that is already narrow from this constantly growing plaque. So why do we learn this? You need to know how this disease works in order to be able to prevent the progression of plaques, because consequences of atherosclerosis will kill your patients. So we can have progressive stenosis, which leads to angina because there's decreased ability to supply the heart in the case of coronary artery involvement. Remember, the myocardium already extracts 80% of the oxygen from the blood that is being delivered to it at baseline. So in addition to the stenosis of the lumen, the presence of this plaque can actually disrupt the diffusion of oxygen and nutrients to the intima and the inner layer of the media. This leads to intimal and medial necrosis. Necrosis means it is weak, which means that we have a really weak vessel wall. What is particularly high yield is that in the abdominal aorta, below the level of the renal artery bifurcations, is where we have the highest risk for development of these plaques and progression to cause aneurysms. This is because for some unknown reason, we do not have vasa vasorum in the adventitial layer below the renal arteries in our abdominal aorta, which means that oxygen and nutrients have to use this diffusion mechanism to travel through the intima, media, and adventitia directly from the blood that is traveling within the lumen. Atherosclerotic plaques kind of look like a roadblock, don't they? There's not going to be much diffusion going through here at all. Nope, not that. These plaques will greatly impede diffusion and the subsequent necrosis of the cells in the adventitia first, followed by the external elastic lamina, then the media. This makes an incredibly weak vessel and makes the formation of an aneurysm rather easy. As you can imagine, this can just balloon out. All you need is a little bit of increased pressure because that will occur with blood flowing through the stenotic lumen of a weak vessel, and bam, aneurysm. So what are some other potential complications of atherosclerosis? How about ischemia, infarction, peripheral vascular disease, and thrombi or emboli? Ischemia, infarcts, and peripheral vascular disease are all related to the fact that the atheromatous plaques are causing stenosis. We're going from a lumen like this to this. As you can see here in the drawing, the narrow lumen decreases the perfusion of whatever is downstream to this stenotic lesion. Decreased perfusion causes the muscles downstream, whether it's the myocardium or muscles in the peripheral legs or arms, to be hypoxemic. This causes cells to switch over from aerobic to anaerobic, and we know that anaerobic respiration causes accumulation of lactic acid, and this can be, in combination with low O2, leads to pain. Muscular pain in the heart and muscular pain in a muscle are both the same pathophysiology. The thrombus and emboli are related to the ability of a plaque to rupture. We're liberating all of those necrotic cells and contents, including fibronectin and fibrin. They're very stimulatory for the initiation of a clot. So you get a platelet plug, and you get the initiation of the clotting cascade. If the plaque ruptures, you get an acute formation of a plug and thrombus. If you actually break a large plaque, you can release some large fragments of that plaque, and you can actually activate the formation of platelet plug and clot on these mobilized segments. So, in addition to that, you have the risk of a single thrombus mobilizing from a plaque ruptured site. So, that's very dangerous. Thromboemboli can kill you. Excellent. We spent a lot of time on that, and rightfully so, because this will be on your Step 1 exam.